and welcome to this 6th edition of the University webinar series of the Tamil Nadu Dr. M.G.R. Medical University. The university had been, as most of you are aware, conducting webinars every fortnight on the first and the third Fridays of every calendar month. Since it happens to be the pandemic time, almost all our webinars until now have been on COVID-19. And this afternoon, I'm sorry, it's for the Indians. For the rest of you, morning or whatever time, this day, our discussions are once again going to be on COVID, on a very, very important aspect that COVID-19 has triggered, the psychosocial aspects of COVID-19. On one side, we find almost everyone is becoming a patient and the psychological depression that it causes. On the other side, families are losing people to COVID and the kind of psychological trauma it leads to. There are children who have been orphaned, children who have lost one parent, mothers and fathers who have lost their sons and daughters, wives and husbands who have lost their spouses, and so on. Kith and kin, whomsoever was available yesterday, are not there today. And I'm reminded of one of the verses of the famed Tamil poet Thiruvalluvar, Nirnal Ulan Oruvan Indrillai Ennum Perumai Padaithu Ivvulagu. It was a very pure question. What is the speciality of the world or the earth? And Thiruvalluvar said, someone who was alive yesterday is not alive today, is the speciality of life and speciality of the earth. And COVID is giving us a hard blow to understand, making us understand this the hard way. And so this edition blooms to discuss about the psychosocial aspects of COVID-19. We have 3 speakers for the day. Dr. Hosekere Aditya from the NHS Scotland, talking to us on the psychiatry of COVID-19. Dr. Maitreya Mukherjee, consultant psychosocial support at the National Disaster Management Authority, New Delhi, talking to us on the counseling aspects. And then, of course, Dr. Jagadisan, professor of psychiatry from Madras Medical College, discussing about the psychological needs and well-being of children and adults during the COVID pandemic. However, we have a lead expert here with us. On one side, I welcome him as the expert who would lead this panel this afternoon. On the other side, he's very much part of our university, being one of our own governing council members, Professor Dr. Gangadhar, the former director of the NIMANS Bangalore, and currently the president of the EMRB National Medical Commission, New Delhi. I would request Dr. Gangadhar to offer his opening remarks with regard to the psychosocial aspects of COVID-19, following which we will have Dr. Hosekere Aditya. Professor Dr. Gangadhar, welcome, sir.
Thank you, madam. Thank you very much.
And the floor is yours.
Yes, thank you. Thank you very much. Very nice of you to invite me to this webinar. I'm sure your approach to the whole problem is going to be recognized greatly, particularly the psychosocial impact of COVID is something that we have all recognized as a significant issue in this pandemic and the disaster situation. So many things have happened in the last 1 year. I don't want to repeat those developments that have happened in the country, both at the national level and at the NIMANS level when I was earlier there, the director, and I'm sure many of those helplines that spontaneously sprung up at all the Indian Psychiatric Society, state chapters, and many other volunteers, NGOs. So there has been a good amount of work that has happened in the area of providing psychosocial support. I know that there are some who have also been offering stress reduction programs, yoga sessions, and Imans also has opened these yoga sessions for all the people who may want to find relief from the current stress of various components of COVID pandemic and disaster. So I'm sure you have elegantly made three chapters, three different topics which are going to be discussed in children and in the stresses and in the pandemic. Very going to be very useful. I can straight away say that at the outset. There is another component which although not directly involved in illness, but I think it is something called as health psychology. There is a component of behavioral change that has to be introduced in virtually everyone to be able to guard their health, to be able to be disciplined, to be able to be attentive to those guidelines that government gives from time to time, whether it is about the mask, about the distancing, or about following some other precautions that are required, like hand washing, avoiding crowds, and so on and so forth. And also, of course, the vaccination. So this behavioral change and attitudinal change to all uh, these disciplines or lifestyle that has been now required. Of course, adapting to this lifestyle, the stress, etc., we have always been discussing. What seemed to have somewhere missed in all the earlier webinars and many other programs on psychosocial distress and psychological preparedness, etc., etc. I have been seeing over the course of last almost 14, 15 months, this concept of how to bring this behavioral change, which comes under the concept of what we generally call as health psychology. Somewhere, maybe, if not in this session, I'm sure some of the eminent speakers would be alluding to those areas as well. And in case it is missed out, Madam, I again appeal to you somewhere at some point of time, although it is not directly an illness treatment related thing, but it has a indirect consequence on prevention. So this is particularly required in this pandemic era, pandemic of an infectious disease, which is going to be sustaining for a long time. So, having said these points, I must congratulate Dr. Sudha Madam for making this webinar very timely, very much required. And I also see an issue related to child mental health or the psychosocial consequences in pediatric age group also is being discussed. I'm sure this is fruitful to those who are participating. I already see as many as about 30 or 40 people who have logged in. I'm sure some would be seeing it without having to log in, but through some other YouTube or other real-time viewing channels as well. Wish you all the best. I congratulate each one of you for having participated in this program. I will remain connected as long as my next meeting starts. I won't disturb you, but I would simply log out maybe at about half an hour from this point of time. Wish you all the best, and thanks a lot, madam, for inviting me to this webinar. Thank you very much.
Thank you very much, sir. Thank you very much. That was a wonderful start. And most importantly, your point regarding health psychology, the behavioral changes which are required. I think I personally feel whatever COVID-19 has done to the world, that apart, it has also given us the opportunity to introspect individuals, introspect customs, introspect behavior, introspect societal attitudes, and so many things. I'm sure The point that you have touched upon would definitely feature in this day's seminar. Thank you very much, sir. And I do find Major Dr. Raja, our former Vice Chancellor, amongst the audience. Sir, welcome, sir, and your guidance will always lead us the right way. And I also find Dr. Pala Rajesh, the Vice President of the Royal College of Surgeons, Edinburgh. Anna, welcome, and your participation makes a lot of difference. Thank you very much for being with us. And welcome to everyone. I do find lots of experts here. I'm sorry I would not be in a position to mention every individual name for paucity of time. Let's get going with the event as such. We have Dr. Hosekare Aditya, the consultant psychiatrist and managing director of the Manasa Hospital, Bangalore, and currently the consultant NHS Scotland with us, giving us the first food for thought today, psychiatry of COVID-19. Dr. Aditya is the CEO of the Richmond Fellowship Society, Bangalore 2. He is a fellow of the Royal College of Psychiatrists, UK, and a consultant licensed psychiatrist in the NHS. He completed his postgraduate training in psychiatry in Edinburgh. Anna, that's your clan. And went on to specialize in neuropsychiatry and licensed psychiatry. He is currently working towards a research degree on the psychosocial aspects of cosmetic surgery in the University of Edinburgh. He's a Scottish improvement leader with an interest in improving the quality of mental health care and is actively involved in teaching and training. He has set up one of India's first online internship programs for psychology and teachers, an online master's course for psychiatry in the United Kingdom. Welcome, Dr. Aditya, and we are waiting to learn from you. Yes, Dr. Aditya, please.
Thank you very much, Dr. Sudha Sheshayan. Thank you so much for inviting me. I'm going to share my slides. I need to know if others can see.
Yeah, please.
Also, I'd like to take this opportunity to thank Dr. Thirupugal from NDMA for introducing us, and also to Dr. B.N. Gangadhar, who has given us the foreword. It is always daunting to speak among so many experts, because suddenly you realize you are not the expert in the field. However, I'm going to stick to what I know best, which is clinical medicine. And I'm just going to play this slideshow in the hope that you can see it. And so I'm a clinician. First and foremost, I'm a clinician. And I'm going to talk today about the things I have learned from my patients, who are my biggest teachers. And most of my medicine I have learned from my patients. So today I was going to talk about 6 or 7 lessons that my patients with COVID-19 in both Bangalore and the UK have taught me. And I'm going to try and use as many images as possible so that I don't bore the audience. But also I will have for the few students among you, I was thinking there may be some students as well, including my own. So there are references at the bottom of each slide to the current papers that are on which the talk is based. So in addition to those bits that I've talked about, these are my affiliations, as Dr. Sudha Sheshayan has very kindly said. And we've had the introduction, and I was going to talk briefly, and if there were more students in the audience, I was going to talk about the 4P model, on which most of our diagnosis and formulation is based in mental health, but also in the rest of medicine. For those of you doctors and junior doctors and trainees who are not psychiatrists and not mental health professionals, I urge you to have a look at this, because it's a very interesting and useful way to look at the multi-morbidity that all our patients present with, not just COVID-19, but every condition. And we'll talk along the way of lessons that I have learned from my patients. And we'll summarize, and there will be time for questions and answers, I think Dr. Sheshayan had said. So I welcome those as well. This is something that I apologize. There are so many senior doctors in this audience, so many experts, that this is not news to most of us. But for the few of you, if it is new, I'd like to urge you to look at every condition that you see, every patient that you see through this framework. That the problem that they present with has a predisposing tail. What predisposed them to present to us? What pushed them over the edge? What is maintaining their illness? Most of our conditions are self-fighting. Why is it that this patient has not fixed themselves? Why is this person's brain still malfunctioning? Why are they here? And what is it that has protected them, and what is it that will protect them again in the future? That's the fourth P. But of course, every condition, whether it's ischemic heart disease, whether it is epilepsy, whether it is depression, has biological, psychological, and social elements. And if we miss any of them, then we miss the reasons for why the patient is with us and how best we can help them. So using this framework, I was going to talk about the lessons that our patients have taught me. And the first is the simplest one, which is in any condition that a doctor sees, any patient that a doctor sees, the first thing we notice is that it is not just the illness that is the problem, but it is who the illness is affecting. So depending on who we are as a personality, what our strengths are, what our weaknesses are, when we have an illness, those conditions manifest differently. And so it is with COVID-19. Now, many of us will be looking at the screen and saying, oh my goodness, signs of obsessive compulsive personality disorder. I score a lot of these. But that is not unusual. A lot of doctors, a lot of healthcare professionals, a lot of leaders have all of these as their strengths. And the point I'm making is in severe conditions, these strengths can become our weaknesses. So the pursuit of perfectionism is so important in healthcare and in leadership. The attention to detail, the organization, sometimes even rigidity is important and formality. But it does make for better professionals than better human beings. And many of us who are very good at our work may not be as good in our personal lives. And it is so with COVID-19. Many of my patients who have had obsessive compulsive features, doctors who have been worried about contamination, about infection, have found it extremely difficult to manage the additional strain of public contagion. And this is something that we all know, but it has been a lesson that has been useful to relearn, that if we are already anxious people, then the anxiety of a public pandemic makes our lives much harder. Of course, conversely, some people have found that once we have something real to worry about, then obviously, in fact, our anxiety suddenly becomes more productive than it used to be before. Somebody has annotated my screen. I'm just going to try to change it. Yes, thank you. What's been unusual about COVID-19 is that we expected, like with any major illness, and of course, although I say talk about pandemics as if we are used to it, this is the first major pandemic that is affecting us that many of us can remember as day-to-day clinicians. I'm sure professionals like Dr. Tirupugal have seen epidemics before, and to them it is not unusual. But for many of us doctors on the front line, it is unusual to see something that is affecting so many people all at once. And so as psychiatrists, we expected there to be a lot of adjustment disorder. What is adjustment disorder? It is exactly as it sounds, which is you have a lot of stress and it is difficult for you to manage that stress based on your usual coping styles. And then you start developing problems that we would call adjustment disorder. That is what we expected. And in fact, we do see quite a lot of it in the general public, many of whom have never suffered COVID and many of whom will never suffer COVID, but will have anxiety, stress, and plus all the social problems that COVID-19 has brought. But what has been unusual about COVID-19 is the timing of some of the mental illnesses that we have seen. You'll see on that list that actually we're seeing a lot more conditions that we had not expected. The amount of insomnia, and I will talk about this, has been very unusual. We didn't expect to see isolated insomnia in this proportion. And there is something unusual about COVID-19 in that respect. What has been unusual also, and I was going to talk to you about one particular example, and I should tell you some of the slides I've got from Google, but many of them are from some of the work that we did with Dr. Tirupugal's team in the NDMA last year, where I was their advisor to mental health. And we did some Twitter feed messages to the country to see, is there any way of raising awareness of mental health during COVID-19? So this is one of the slides that Ms. Maitreya Mukherjee was also involved in, which is about depression. And, obviously, these are things that most doctors and most people seem to know, that there are many features of depression. What has been unusual for me as a psychiatrist is that I had expected to see it in people who were adjusting to COVID-19. what I had not expected to see and what has made me very interested as a neuropsychiatrist is the fact we are seeing people with very mild conditions presenting with this. So I see many IT professionals. One of them recently saw me who had a very mild COVID-19, so mild, and I don't know if this is a problem just in Karnataka, I hope it is limited to us, that he had a good friend as a doctor who in the beginning of the COVID-19 problem said to him, I don't think you should get tested, because if you get tested, then they'll put you in a hospital and you'll get more ill. I will manage you in your own home. So don't get tested. I know you have anosmia. I know you have a fatigue. I know you have fever, all the symptoms. I know you have COVID-19, but we will manage you at home. And actually, he did very well. He had a very mild COVID-19. At no point was his life in danger. His family were doing well. He had 2 young children. He has a very well-paid job. So he's one of the few people in the country who suffered no social consequences of COVID-19. And yet, within 2 weeks, he's become so severely depressed that he was suicidal. And it was very difficult to treat him. No amount of medication, therapy, none of it. Over 3 months, we tried very hard to help him. And he just got worse and worse and worse until we had to use neurostimulation, admit him, and get him better. And he is much better, I'm happy to report. But what is surprising was the level of depression in someone with no previous history of depression, no vulnerability features, nothing that would have predicted this level of depression in someone who has otherwise suffered a very mild viral illness. And this, again, is special about COVID. It is surprising us in unusual ways. Of course, are not strangers. I apologize, I've used a few Chinese papers because they were the first off the blocks, and they've had much more time to publish their papers. But long COVID is not something that is unique to China. We are now seeing it, people with a lot of COVID symptoms after they've returned home, after they have ostensibly recovered from their initial viral illness. And of course, we've heard of the usual ones, the lung disease and the fatigue, energy are those. But in mental health and neurology, we're seeing a lot of symptoms that are unexplained. They are not entirely as we expected, the paresthesias, the myotonias, the pains in the arms and legs that we can't fully explain, persistent symptoms. And of course, a lot of mental health problems that we see with it. What is really interesting to me from my neuropsychiatry perspective is what it is doing to our neurology and our brains. There is a lot of new work that is really interesting about how the coronavirus itself enters our body, and there is work on the olfactory bulb and the ACE inhibitor and how it may actually be able to affect our neurological system as quickly as it infects our respiratory systems. Yes, there is already work on the kind of stroke disease that people are suffering. And I know the poor vaccines are getting the blames for it, but of course the virus is much worse in terms of causing strokes within us, and that includes the brain. It hasn't spared our brains, and the vascular disease that we are seeing elsewhere in the body is affecting the brain. The hypoxias that we are seeing. So in Edinburgh, the brain injury unit, Alistair Fitzgerald and I published the world's largest series on anoxic brain injury. And what we have noticed is that certainly with COVID-19, we expect a lot of subclinical hypoxias to be affecting people's cognitive function and their brain functions. And many of these people will return home never being diagnosed with any kind of hypoxia, but will have long-term sequelae as a result. The treatments themselves, as we have found, including high-dose steroids, are causing psychological and neuropsychiatric problems, and not just mucormycosis, a lot of problems that we as psychiatrists are interested in. In the biological end, one of my colleagues who's a professor of psychiatry in Leicester has been on YouTube talking about the severe delirium that he suffered. He's a very bright man. He's one of the top 1% cited clinicians in the world, researchers in the world. He suffered a severe delirium and psychotic features, and he has been on YouTube talking about psychotic features. We are seeing a lot of people with neuropsychiatric sequelae that we had not expected, insomnia among them. And this is another slide we had for insomnia. And one of my colleagues in Manasa is a psychiatrist, a very senior psychiatrist, and no history of mental illness, no history of insomnia, had a very mild COVID-19 and has suffered months and months and months of insomnia. And one of the things I have realized with him, as with my other patients, is that the insomnia of COVID-19 seems to respond slightly differently. Having used very little melatonin before, we are now using much more of it. So it appears that it damages sleep architecture in a way that is not wholly related to anxiety and depression. And there is something toxic about COVID-19 to the sleep architecture so that when people recover, they require medication that resets their biological clocks, like melatonin, in addition to these other sedatives that we have been using. This is the easy bit. One of my childhood friends recovered from a time in ICU and came back home. And in passing, we went for a walk. He can't go for a very long walk now because his fibrosis, lung fibrosis, is still recovering, and it's. But he says that every time when he goes to sleep and goes to bed and he closes his eyes, all he can hear is the pinging of the ICU monitors. Every time someone moves near him, he worries that there is a nurse near him. He can't watch TV without anxiety. And he has a lot of memories and nightmares of his time in ICU. ICU PTSD is very common, but in COVID-19, there is something special about it, not only because there is such a fear of death, but an isolation from one's family during the treatment, because it's almost unique in India that we have had an illness where your family cannot be by your side, showing you their love and affection and how much you are needed. So many people in ICU spending so much time on their own, at best having some brief Zoom conversations with their family, mostly not even that. So we're going to see a lot of PTSD. We're already seeing it. We're seeing a lot of anxiety and depression as a result of their ICU stays. And this is not surprising. Our chartered accountant, who's happy for me to talk about him, extraordinarily bright man, who's a fine, upstanding man, known across Bangalore, lives in his colony, has lived there for 30 years, tells me that he used to be able to enjoy going out in his colony and saying hello to every single person that he passed. He now goes out only at night because he is ashamed of the COVID he suffered. Not because it is his fault, but he is worried that people will cross the street if they see him. Paradoxically, those who have had COVID and returned home are much safer to us. They're not a threat to us. And yet there is so much stigma that I think our country is going to have to deal with these issues much better than we currently have. And of course, what I have not talked about is the other social elements, which is poverty, hunger, and the bigger social determinants of health, which as doctors, we are not very good at addressing, but others are. And I'm very glad to hear, to see Dr. Tirupugal in the room. And I think his department and the government are more likely to be taking a leading role on that front. There are some things that we don't talk about, even in India. Domestic violence has gone up enormously across the world. It is just one example of pre-existing social problems that get a lot worse as a result of a pandemic such as COVID-19. And intimate partner violence, which is what the WHO calls it, or domestic violence, has become much worse. The average mental health professional is seeing a lot more marital problems coming to their practice in our hospital. Is no different. But more important than marital problems is this: the kind of abuse and violence that goes on within families have got worse during COVID-19. The social stresses, the poverty, the loss of job, the threat of loss of employment have all worsened domestic environments. And it is something that I think we have not yet come to terms with. And I am not sure as a doctor if I have a clear solution to this problem. I think it will be a societal solution. As usual, my patients have taught me that what has been helpful are families and protective environments. The big difference between the UK and India is the quality of the family relationships that we have, the size of the family support that we have. One of my patients runs a chain of chart shops in Bangalore, and he was extremely anxious. And I treated him and I wondered whether he had major problems. But I realized every time I saw him on his Zoom call, is that his whole family would come and sit in the background while we were consulting. 6 or 7 of them would sit along with him during the consultation. He did very well with his anxiety, and I realized that his family took as much credit for his recoveries as I did. And I think that's a good thing. And he's a very gentle man. He's very altruistic, who cares more about his employees and customers than he does about his own health. And he has done wonderfully well with his anxiety. But it reminded me, and his health reminded me, how important it is to have a good social network, a good support network, and how difficult it must be for all those people who are working far away from home in India, in different states, having to return home to their family environments. It's not just money that is driving them back home. I think it is the need for relationships, the need for connection that is driving us all back home. So the lessons, I think there are some very predictable lessons. I think, forgive me for saying the obvious, it is not just a respiratory virus. It is so much more. I have a lot of respect for COVID-19. And I fully support everyone's efforts to prevent people becoming infected, because I worry that, like the old streptococcus did for heart disease, I worry that for 20 years we will be asking our patients from now on, did you ever suffer COVID-19? And when we look at people with mental disorder. Some of the mental illnesses we are seeing with COVID-19 are very predictable, like adjustment disorder. Some are not. And I think we must consider that COVID-19 has a neurocognitive pathology as part of it. We are now seeing acute delirium, depression, anxiety, insomnia, but we are likely to see persistent mental illnesses. And what I really worry about is that we are going to start seeing dementias. The brain fog that our patients are now reporting, although there has been some report that people are recovering, we are going to see much more of it. Thank you very much. I hope I haven't overstepped my time. That is my Twitter handle. I've not been on it for a while, but those of you who have any questions that I can try and answer outside of this program, please feel free to tweet me. Thank you again, Dr. Sudha Sheshayan, for this opportunity, and I look forward to the rest of the program. Thank you.
Thank you very much, Dr. Aditya, for that wonderful presentation. Of course, what's in store post-COVID and how long this post-COVID would be is a $1 million question that all of us are trying to answer, and with a very fact behind our minds that the question will never go completely answered. We have several experts here in this hall. I find the Dean of Madras Medical College, Dr. Therani Rajan, with us, a pediatrician himself. Dr. Jayantini, a very senior psychiatrist, especially pediatric psychiatrist. Dr. Venkatesh Madan Kumar, Dr. Sabita, who are all psychiatrists themselves. Dr. Kanagavel, a renowned surgeon, and so many of them. Before I request Dr. Jayantini and Dr. Therani Rajan for some remarks on what Dr. Aditya had told us, a few things to remind the audience about from what Dr. Aditya had presented. This long COVID, now much before the term long COVID was even formed, I remember much early in the pandemic, one of the symptoms that people presented with was insomnia. And even in those cases of happy hypoxia, the only presenting symptom was insomnia for a week, and then the patient comes to you walking about, talking into his mobile phone, but still you find the saturation is just about 80 or 82. And that is when insomnia and long COVID were associated. And I remember in the first edition of this webinar series, Professor Lakshmi Narasimhan, our renowned neurologist and director neurology MMC, had even said, probably we'll now embark on a new specialty called COVIDology. And he said his neuro interns were able to see more neurological symptoms in the COVID ward than in the neurology ward. And the virus had been ransacking the entire nervous system. Dr. Aditya, you said the sleep architecture is kind of devastated. Now, are there, apart from insomnia, are there any other features which point to the biological clock being jeopardized? Any associated features or any kind of, dysfunction of the pineal system? Any diurnal markers getting kind of desynchronized? Have you seen anything in your experience?
Yes, ma'am. So that we are now seeing a lot of people with circadian rhythm problems. So it's not just insomnia, but it is shifting of their time clock. Now, it isn't always clear. As a psychiatrist, one of my biases, I always think of a psychological explanation before I think about a biological. But as you say, with COVID-19, it is the other way around. Is it hypoxia that keeps them awake at night? And when I was a medical student many, many years ago, we were taught about paroxysmal nocturnal dyspnea. And I know in Edinburgh, nobody talks about that now. But many of my patients are now describing just that. And they say, I say, well, have you spoke to your respiratory physician? And they say, yes, but our respiratory numbers didn't fall, so no one asked any questions. There is something else going on. There is circadian rhythm problems. And there are, as you say, there is evidence with sleep studies that what we are now doing nowadays is not admitting people to sleep study labs, as you know. Increasingly, there are these wonderful activity bracelets that I get my patients to wear, and they show me that their REM sleep onset, their duration, their deep sleep are all altered. Of course, the big problem I have is I didn't know what their baseline was other than by their description. So I can see that their sleep architecture is disturbed. I can see them that they need more than melatonin, but I am not entirely sure whether COVID-19 has damaged it through a direct neurological effect, which I believe it has, or partly psychological, partly depression related. Many of these patients do not have anxiety and depression, but have very significant insomnia. So it would be wrong for us to say that insomnia is largely due to worry. So in answer to your question, yes, certainly.
Thank you, Aditya. I also find Dr. Ramesh has joined in. Now, may I request Dr. Therani Rajan for his remarks? Dean, sir. MMC Dean, sir. Oh. I think he has some problem with his system. Sir, unmute பண்ணுங்க. Meanwhile, can I have Dr. Jayantini? Madam Dr. Jayantini?
Madam, I am there, but I am not coming on the video. I have zoster in the face.
Yes, ma'am. Yes, ma'am. We wish you speedy recovery. And
Thank you.
Yeah.
What's the question? Is it about the sleep or is it about anything else? Hello?
Ma'am, no specific question to you. Who am I to ask a question to you? I was your student. So please give your remarks, ma'am.
I am seeing a lot of adults coming with sleep-related problems. There is a fear that they may develop dyspnea, which may go unnoticed. So they don't want to sleep. The anxiety persists, and they start sleeping once the other people in the family wake up, so that somebody is there to know whether they are suffering or not. Of course, there are a lot of problems with children, which I will talk after Dr. Jagdish gives his lecture. Okay. Hello.
Thank you, ma'am.
Hello.
Thank you.
Okay.
Yes, ma'am. Thank you. Sir, Dr. Therani Rajan, sir.
Good afternoon, madam. Good afternoon, madam. Therani Rajan here, madam.
Good afternoon.
There's a technical
Yes, sir. Please.
issue, madam. That's why. Madam, thanks for the opportunity, madam. I really want to thank India for highlighting about the post-COVID problems, which we are encountered in our post-COVID clinic also. Rajiv Gandhi Hospital was the first one to start the post-COVID clinic. So we had analysis nearly 1,500 patients. Mainly, they complained about insomnia and sleep disorders. I would like to know what is the difference between the brain fog. They say they are having problem in concentration and memory, all those things. Brain fog. Another thing is chronic fatigue syndrome, which we have already seen in the post-viral state. Is it the same chronic fatigue syndrome is applicable to this post-COVID? And also, I want to know the long COVID duration, because one textbook says 3 months, another one says 8 weeks or something like that. There is no clarity about this. Just want to know from Aditya. Thank you.
Dr. Aditya, would you take them?
Take the first, madam.
Yes.
This is a good question. What is the difference between brain fog and the neurocognitive deficits we see in chronic fatigue? I don't think we have known yet. I think some of the brain fog is chronic fatigue. You're absolutely right. These are people who are presented exactly like the post-viral chronic fatigues that we have seen for many years for other conditions. But the brain fog that we are seeing, we think there will be a second peak in terms of evidence, and there will be a cluster of people who actually have mild cognitive impairment, who have suffered not just due to their chronic fatigue-like picture, but due to a direct neurotoxic effect. I'm confident that we will see more neurological deficits, neurocognitive deficits, other than just chronic fatigue. Now, I don't want to say just chronic fatigue as if it's not serious. chronic fatigue can be. Some of our patients don't recover at all. But post-viral chronic fatigue, you would expect recovery. And in fact, we are seeing cognitive recovery in a very large number of patients in the way that you would see with post-viral chronic fatigue. So that's tiredness, muscle aches, low-level depressive symptoms, but not a lot, and effectively functional loss, and some level of, as you say, brain fog, can't concentrate, can't remember, that kind of thing. But when you do formal cognitive testing, they don't have serious deficits. But we do think there is a second group of people who will, I think, cluster out with time, who are not recovering and for whom the problems are not directly linked to the fatigue that we see, who are experiencing, as I say, just brain fog. I'm now seeing people who deny any fatigue, deny any other thing, but they're saying things like, when I go to work, I have to now write down all the things that I'm doing for the day because I cannot remember. And when we test them, and bear in mind the tests that we have in psychiatry and neuropsychology are fairly crude. So these are extremely intelligent people who we are testing. They score quite highly in their scores, but they have lost two things. One, the innate ability to remember like they did. The second thing that they have lost, and I think one of your speakers contributed to it, which is the confidence in their own cognitive performance. And that is a huge part in it, which is, can I remember? Can I do this? They have lost the confidence of being a well person. Many people who have suffered COVID-19 are people who have never suffered illness before. So some of these people, I think, may be behavioral. Their own self-confidence has gone. So maybe when their self-confidence recovers, maybe their cognitive performance will improve. But I think your question is a really good one. I don't think we have the answer yet. Is there a huge difference? Are they clustering differently? Brain fog versus chronic fatigue? Not yet.
Thank you. Dr. Ramesh. Dr. Ramesh, I saw you in. Dr. Raju Ramesh.
Yes, hello.
Yeah, Ramesh, anything that you would want to say? Because I remember you were talking about a lot of these insomnic people approaching you and so many things. Yeah.
Actually, I deal with a lot of acute COVID cases, especially ones on ventilator, either invasive or non-invasive, mainly non-invasive. People on high flow oxygen, hooked up in so-called COVID wards, out of touch with surroundings and out of touch with their usual people they see. The COVID restrictions as they are prevent us from interacting too closely with these patients and definitely not allowing their near and dear ones, the relations, the friends, or to come and see them. Lately, I think we have found that there's a great deal of help to the patients to have the relation or friend, wife, husband, brother, uncle, whatever, come and have a look bedside. We do, of course, have video calling, we have video things like that, but that doesn't help. So, with the help of a counselor, what is your idea about that? And how important is it to have eye-to-eye contact, some sort of, perhaps not physical, but at least close visual contact, some counselor, to a patient who's coped up in the ward for 6-7 days, staring at the white ceiling, and attached to a lot of tubes and seeing death around him. What are the views on that? Because we have restrictions on who can come into the COVID ward and so on and so forth. So what are the ideas?
Dr. Sudha, do you want me to take that question?
That's to you only. Yes.
Sorry, thank you. So I think that's a fantastic question, and your observation is absolutely right. If I had a way of getting families and loved ones into the ICU and thing, then I would have that, because I think that is invaluable. The connection to our family is so strong and so important that no therapist, no counselor, no psychiatrist can replace that. So when you see people with isolation who are suffering in ICU, having a psychiatrist go and speak to them sometimes helps because we have the time to talk, but it is not the same as connection with their family, whether it is by phone or by screen. And as you see, there are so many things going on. The one added thing that is going on that is very common now is the fear of death, and the fear of severe illness is so strong in the general public. There is a fear about COVID-19. So even when you are having patients who are recovering, their health anxiety is so high. Also, many of our patients now know that just because you are fine on the first 5 to 7 days doesn't mean you have cleared the danger mark and that you could have late complications. So having a family member present, having loved ones present, having that connection is very important. Although it is very difficult, I was wondering if there is a way where teams can make it a point to say, irrespective of how early it is in the illness, We will have regular contact with the family, irrespective of what the patient looks like and how they are, so that families can see and the loved ones can be connected. Of course, when you have a severe COVID-19, then you will wake up one day and feel completely isolated, and it's very hard to plug them back to their family. But if there is any way to have family members present, either on their television or on their videos or on the handheld phones that the nurses seem to have, our nurses have been fantastic. They're the ones who are leading the way. They bring, I think, contact with their families. Nurses are much better than doctors, I find, because there is more compassion in them. They're more used to sitting down, holding hands, doing the things that as doctors, sometimes we don't have the time for or feel a bit uncomfortable with. As to whether psychologists and counselors can help, perhaps. But my own biased opinion is what we may need is much more people with much more experience of life, where what is needed is compassion. It is not therapy that these patients need at that stage in ICU and the wards. They need a human connection. And it doesn't matter. You don't have to have a psychologist or a psychiatrist. Any warm, compassionate, sensible person who can just give them a sense of being connected and being cared for, remind them of who they are, remind them that there's a family who cares for them. That is enormously important. Any photographs you can have, any videos that you can share, all of that is time worth spending. It will reduce the post-ICU morbidity. Somebody asked this question in the chat group and I've just answered it. What are we doing for PTSD post-ICU? In Edinburgh, typically what we do is we have a lot of professional systems. So we have a team who will assess everyone in their ICU and then follow them up afterwards. But if we get families involved, I wonder whether the prevalence of ICU delirium itself will come down or the duration of post-ICU PTSD will come down. It is just a theory. I have not tested it, but it's worth seeing whether having family connected reduces the mental morbidity of these patients.
Dr. Ramesh and Dr. Aditya. Yes, Anna, before I ask you to speak, Anna, I'll just say a few things out of my own experience. I had a few friends, quite mature people, journalists and other kinds of friends who were struck down by COVID and were admitted. And of course, not very seriously ill. Probably you could grade them as moderately ill, caught inside the individual rooms. And what happened during their admission was that second day, third day, they started calling some of the other friends. Like I also received calls from some of them, trying to kind of say, lament, like, feeling very bored, feeling let down, feeling depressed and things like that. Then I kind of found this issue. So what I started doing was talk to them every evening. Every evening at the desired hour, maybe, 6:30, 7 o'clock, 7:30, or if you have 4 or 5 people, keep a kind of a timetable. And then keep talking to them, forget COVID, talk to them something else about their own books, the way they write. And, there are so many things under the sun to discuss and talk. And I found that worked, in some kind of a way. And if I forgot the 4th day or the 5th day to make the call, they would make the call. And I think it did help in some way. And all along the complaint was, Amma bayama irukku, thaniya irukumbodhu bayama irukku, nee pesinana, we feel confident. And I also found some of them resorted to listening to music, and some kind of lectures, something which would give them some kind of solace. So probably we can think of a partial solution here. Kith and kin, somebody could make phone calls and talk to them. And then I do agree with what Dr. Aditya says. I think Dr. Therani Rajan would remember, in some of these hospitals, our own hospitals, there were demands for video calls to be made. I remember one instance, I would not quote the name of the hospital, but then one of the grandsons, the grandfather was admitted very seriously ill, almost dying. The grandson had secured a gold medal in another country. And then the grandson called up and said, I want to show this medal to the grandfather. And the band of doctors there made some kind of arrangement. A video call was placed and the grandson was able to show call the grandfather, say, Tata, Tata, I've got this, please see this medal. And the Tata was also happy to see the medal. And of course, few hours later, the Tata passed away. But then that gave some kind of binding, like probably the Tata also felt happy, and the grandson, at least he would not be nursing a kind of a grudge, lifelong grudge, saying that I was never able to show this to my grandfather. So some kind of arrangements, innovative arrangements could be made, probably that could be thought of by the people in the field. Yes, Dr. Rajesh, Dr. Pala Rajesh wants to say something. Yes, Anna, please.
Thank you. Thank you very much, Sudha, for having me today in this wonderful webinar. I will have to leave in the next 5 minutes as I have another webinar with the WHO. So I thought I'd just say a few things before I dive out of here.
Yes, sir. Yes.
To talk about long COVID, I'm sure Aditya knows that the NIHR trial in the University of Leicester has commenced. And this is not going to give us an answer now. There will not be any clarity in 3 months. There will not be any clarity in 6 months or at the end of the year, because they're going to recruit. We'll need to study, we'll need to analyze, and we'll need to come up with what is the answers at the time, because we're still learning about COVID. We know it's an endothelial dysfunction. We know that it's not just the neurology, but all the other systems. And therefore, this, I think, will be an ongoing research tool for probably the next half a decade. Now, having said that, we are talking about patients. We're talking about the interaction that the patients need. But don't forget, the people who interact with them are the nursing staff and the medical staff. In my own specialty of cardiothoracic surgery, where a death in the ICU is taken extremely seriously, and the teams debrief, and we want to go through what we could have done better, imagine that nurse having to interact with so many human beings in the intensive care, where she's not doing just one shift because of the shortages that we have in the NHS, which Aditya clearly knows, and in his specialty, it's appalling in Scotland. And therefore, just imagine those human beings. They've got homes. They've got to go back to their homes after probably doing more than one shift, discussing very intimate relationships with strangers, and a lot of them dying. And imagine the resilience that these nursing staff and the doctors who've been deployed from their practices, which they're not used to. You know, people who are orthopedic surgeons in the intensive care, that in itself is an anxiety. And then to see that people are extremely ill, learning very quickly on the hoof, and then going home and lying in bed and thinking about the deaths that have happened, and also thinking about the children and the spouses who are not with them. Some of them have been billeted in hotels for 3 months, for 2 months. So this is an enormous societal problem. Insomnia is probably one of it, but the anxiety which you create, which just, completely unseats the circadian rhythm, the diurnal variations, children, relatives, friends. So I think this is going to be a problem all over the world, which is not going to end this year or next year, but it's going to carry on for a long time. And on that sad note, I have to leave the meeting as I've got another one in about 5 minutes' time. Thank you ever so much for requesting me to participate in this wonderful webinar this morning. Thank you.
Thank you, Dr. Rajesh. Thanks very much. I think we are running behind schedule a little, so probably we'll get to the next speaker and then come back to our discussions. We have Dr. Maitreya Mukherjee, who is the consultant for psychosocial support at the National Disaster Management Authority, New Delhi, who would be talking to us on psychological counseling during COVID. Dr. Maitreya is a senior consultant for psychosocial care and social vulnerability reduction at the NDMA.
This meeting is being recorded.
She has over 18 years of experience in the development sector in India and abroad, and has been associated with different agencies like the UNDP, IFAD, Oxfam, ActionAid, Aga Khan Foundation, and the University of Leeds, among other national and community-based organizations. She has completed a master's in social work from the Tata Institute of Social Sciences, Mumbai, followed by another master's in development studies and gender at the University of Leeds, United Kingdom. Yes, Madam Maitreya, it's yours now.
Thank you so much, ma'am. Am I audible? Yes, okay. So thank you, madam. Thank you, esteemed panelists here. Thank you, Dr. Thiru, for giving me the opportunity to talk about the interventions that NDMA has taken in the COVID-19 pandemic. And first of all, I would like to thank Dr. Aditya for supporting us initially when we had started out with the establishment of the psychosocial care helpline for NDMA. He, at a time when we were not very sure as to how we should go about establishing the helpline, what kind of like SOPs we needed to develop, what kind of training we needed to give to our counselors, Dr. Aditya was very kind in hand-holding us for the initial period. So thank you, Dr. Aditya. With your guidance, we have carried it forward. And I would like to present a small presentation on the different activities that NDMA has taken for providing psychosocial care to the COVID-19 people. So if I can start my PPT. It's taking a moment.
It's fine, ma'am, please.
Know that you're here.
Hello. Hello, ma'am. I'm sorry I got disconnected. Hello.
Dr. Maitreya, you're inside.
Yes. I joined in by mistake. I had logged out. So I've joined back. Please allow me to share.
Yeah, please, ma'am. There are two instruments she's joined in. Your screen is seen. Please go ahead.
Okay, ma'am. Okay. Thank you. So I'm going to talk about the initiatives taken by NDMA for providing psychosocial care support. And basically, my presentation is based on the value of compassion, which Dr. Aditya was talking about. We have based all our interventions on the belief that empathetic listening, a compassionate hearing, and enabling people to have a catharsis helps to assuage a lot of the sufferings that people are facing in this COVID-19 pandemic. So we have issued advisories for disaster management authorities in India who have to tackle with this mammoth task of disaster management in the country. We have issued advisories for disaster management professionals. We have seen cases of suicide among our professionals in the state disaster management authorities and district disaster management authorities. So we have issued advisories on the way forward. And we have also issued advisories to the states for addressing the psychosocial impact of COVID-19, how they can establish helplines, how they can take care of the people in the isolation centers, in the isolation wards, in the hospitals, and when people come out of the hospitals, at the community level, at the NGO level, what steps could be taken. Then we have run IC campaigns where Dr. Aditya was also a part initially. We have shown the do's and don'ts for psychosocial resilience building in COVID-19 patients. And last but not the least, we have also started the helpline for people testing positive for COVID-19. So the main objective of the NDMA Psychosocial Helpline is to provide emotional support and brief counseling interventions to people diagnosed with COVID-19. We aim to empower and support the patients and their families to reach out to services and resources available with them in case of continuing concerns. So we get the number of these COVID positive people from ICMR on a daily basis at NDMA, and this in turn is shared with our counselors who call up these people and provide counseling to them. We aim to provide basic resources of mental health care providers, NGOs, and local helplines in case of acute psychosocial distress. We provide structured training and supervision opportunities for volunteer counselors in order to improve their client experience. And we are also trying to collect and organize the feedback which is obtained from the volunteer counselors to develop contextually sensitive policy recommendations for psychosocial interventions, training as well as supervision. So the feedback that we receive from our counselors and from our patients, we are feeding it back into the systems. We are sharing it with the health departments, with the disaster management authorities at the state level, so that they can improve their policies and subsequent interventions. So it's a very simple two-pronged objective of the helpline that we have. One is to lend a listening ear so that we are able to empower the people to ventilate their fears and frustrations. And secondly, we speak comforting words so that we ease the anxieties and we give hope. So we are not in a position, because it's a telecounseling method, our counselors are situated in far-flung remote areas of the country. We have not seen the counselors have not seen us, and we have not seen the patients. So intensive therapeutic work is not possible. So we have kept a very simple objective and we have achieved the desired outcomes. The main features of the helpline is that it is a reverse helpline. It is not a helpline which the patients call up a particular number and seek assistance, because our belief stems from the fact that many people in the rural areas, in the remote areas, even in urban areas, are not in a psychological state of mind or are not in a position to access this information and are not in a position to take help from these helplines by calling up these people. Many of our clients are from rural areas where they do not even possess a phone. Even if they have a phone, they are not able to have the recharge. They are not able to sustain a mobile network connectivity. So it is a reverse helpline where we call up the people. Many a times we find their phones switched off, so we move on to the next patient, and so on and so forth. Now, the counselors are selected through a screening process, which includes screening of their qualifications and experience. The group mainly consists of psychiatrists, clinical psychologists, counselors, and psychiatric social workers. Apart from English and Hindi, a range of regional languages are spoken by the volunteers that enables them to communicate effectively with their beneficiaries. And also, a mobile application was specially designed whether neither the counselor nor the patient's number is displayed in order to maintain confidentiality. So we have a service provider, a technology provider, to whom we share the details, the telephone numbers of the COVID patients, and they in turn put these numbers in the specially designed app developed for the counselors, and the counselors' numbers are not revealed to the patients, and the patients' numbers are not revealed. We only have details like name, age, sex, state, and district. So the different problems which were faced by the patients and revealed to our counselors are myriad. So some of them are like lack of clarity about isolation, quarantine protocols followed by state. All of these are stresses for them. Lack of clarity regarding chances of infection post-recovery, elderly patients needing assistance for daily routines, pregnant women needing antenatal care and not getting it, physically challenged people needing assistance in isolation wards, patients with comorbidity needing medicines for the other ailments, provision of food appropriate for children in the isolation wards, and provision of female hygiene products, and so on. So most of these problems are based uh, from the calls which were made in 2020 last year. So we had our helpline from the month of April 2020, which ended in February 2021, and these problems were seen mostly in that first wave of COVID-19 pandemic. The different psychosocial concerns ranged from health and medical concerns like COVID symptoms, recurrence of the COVID infection after treatment, comorbid conditions, fear of death, issues with test results. Then we had a lot of concerns of the people about the medical facilities and services. We had behavioral concerns, changes in appetite, sleep patterns, as we saw in the first presentation, financial concerns, emotional concerns, relational concerns, stigma, isolation, and logistical concerns. We found that the emotional concerns pertaining to sadness, depressed feelings, loneliness, anxiety was reported by 80% of the people with whom we spoke, followed by health concerns, and then followed by relational concerns. And we had a high percentage of people reporting medical concerns, which was about 24.65%. So this is the range of different kind of problems that were reported by the people whom we called up during that phase. So as was spoken by Dr. Aditya, our counselors emphasized on family support, reiterated faith in God. We tried to motivate them and make them positive about recovery. We shared positive coping strategies. And then definitely after the brief counseling talk, the people, they expressed relief after having shared their anxiety with us. And in many cases, in very many cases, they were very happy that they were contacted in the first place. Many a times people reported that they were not in touch. Many people had not divulged their positive status to families. I'm talking about the first phase of the last year surge that we had. So they were very happy to talk to a person who's calling them anonymously, though in our calls we would always say that we are volunteers calling from NDMA. So the amount of gratitude, the amount of happiness and relief expressed by these people after the brief talk that we have with them was really overwhelming. We also had training and supervision sessions for our counselors. Training sessions were planned after conducting a needs assessment with the counselors. Based on the needs, modules for training were designed and delivered to cover key knowledge, skills, and perspectives. Regular supervision sessions provided personalized inputs and case-based learning for the counselors. And Dr. Aditya was, we had the privilege of having him to conduct the first orientation session for our counselors in the year 2020. So the training topics covered were mainly on psychosocial first aid, the counseling skills, how to assess the needs of the clients, then principles for working with practical needs, interventions for high distress, anger, anxiety, helplessness, guilt, bereavement, supporting clients at high risk, external and internal sources of risk assessment and intervention, and also dealing with the stigma that this particular group of people faced, and also how the counselors would need to take care of their own selves in order to carry out this counseling work. The impact of the training and supervision program was that it enhanced the competence and motivation of our counselors. We were able to conduct our work based on ethics. We also tried to prevent burnout among our counselors, and by providing adequate training and certification, we also ensured that our counselors had professional growth while carrying out this activity. And all of this, we believe, has led to quality psychosocial care being provided to our clients. There were definitely challenges because the counselors had to shift from the traditional medium of counseling to the medium of telecounseling. They had difficulties in navigating conversations because mostly the clients would share about the practical problems that they were facing, logistical problems, as well as finance related problems. The counselors have also expressed that it was quite a challenge to deal with people who have lost family members and are in the bereavement processes. And the biggest challenge that our counselors faced themselves was that the inability of the counselors to offer immediate help to the clients for their practical problems. So this in turn became a challenge for us, and we had to appoint supervisors for our counselors who would counsel the counselors that this provision of practical help and services was not the objective of the helpline. We needed to empower our clients to find their own solutions and contain their emotions through that brief and psychosocial counseling. Counselors also came across different ethical dilemmas while speaking to individuals. For example, boundary-related dilemmas, to what extent they could reveal about themselves, because the counselors would just call up anonymously. The patient would not know who's calling, and many a times the patient would want to know more about the person who's talking and what was the limit to that. Then value conflicts between the patient and the counselors, between the trainers and the counselors, as well as transference, counter-transference. Apart from the varied logistical and technical and management problems that we faced while running the helpline. Till the end of January 2021, the NDMA volunteers had reached out to over 1.5 lakh individuals diagnosed with COVID-19. We were able to provide a space to the people to vent out their feelings and educated individuals about various triggers that could affect their mental health in very simple terms. Supportive psychotherapy, wherever it was needed, grounding techniques, mindfulness training, and breathing exercises helped individuals cope with their concerns. We conducted a research with the help of Tata Institute of Social Sciences, who was our training partner in this intervention. And we based a research on the daily feedback forms that the counselors would fill up pertaining to each conversation and submit to NDMA at the end of each day. And our researchers also interviewed the counselors who took part in this intervention. And we have come out with a research study which will be soon released in a week's time or so in the NDMA website. We have written down the training components which we have presented to our counselors in the form of a training manual in collaboration with TISS, and this is already released and available on the NDMA website. Our program was featured on the Doordarshan show Aapda Ka Mitra. It has also been highlighted as one of a flagship program by the PMO's office. As a component of our helpline, we also extended counseling services to the personnel of Delhi police who were having a very difficult time in managing the great number of cases that the city of Delhi was facing. And they were very grateful, and they said that it had benefited their staff. So this was a facilitation program for NDMA. Now I'd like to end my presentation from the words of the clients. Some of the clients have expressed to us, for example, this service is very good and it came at a time that I genuinely needed it. The pandemic has been very difficult for me and my child. It was a good thing that I could talk to you. It's not just a phone call, rather an upliftment for an exclusive community who were marginalized from the mainstream of the society due to social stigma. Thank you for calling us. It makes us feel like we are not overlooked by the government, and we feel cared for you when you talk so patiently. So this, and with many other testimonials, it has given us the energy to go forward. And though we had closed our helpline in February 2021, but with the second wave coming in, we have just restarted it a few weeks back, and we have started recruiting more counselors, conducting training, and we have also started the counseling process again. Thank you so much. So that was my presentation.
Thank you, Dr. Maitreya. I have a small question to ask.
Yes, ma'am.
The training module that you were talking about, I learn it's in your website. Can you
Yes, ma'am.
kind of take tips from the training module? I'm asking this on behalf of those free counselors who might be doing it, several psychiatrists who might be doing it at their ends. Are we permitted to access information from your training module and probably,
Yes, ma'am.
improvise on them too?
Definitely, ma'am. And that is the very reason we have put it out as soon as we could on the website, so that it could be used by people who are in this field, people who are engaged in counseling, and they get an understanding of what are the different challenges which come in the context of remote counseling, in the context of COVID-19.
Dr. Venkatesh Madan Kumar, are you in? Dr. Venkatesh Madan Kumar and Dr. Kanagavel. Dr. Kanagavel, would you want to say something regarding the kind of the profile of patients that you meet after the pandemic? Dr. Venkatesh Madan Kumar?
Dr. Sudha, can I step in?
Yes, ma'am. Yes,
Then
ma'am,
can you
please.
see
Yes, ma'am, please, ma'am.
there are two kinds of people who approach us. One is a group who knows us. It is not the psychiatrist, any doctor. From the time they suspect COVID, they start asking for your help in everything. Seeing a doctor, finding a place, admitting, and they give you a status report. And if we continue to give them a support till the end, if you know the patient is very bad, then also we give the support. All they need is, like she has said, the medical help is given in the hospital. The psychosocial support is given not only to the patient, but to the family members right from day one if they contact us. A lot of doctors are doing it without getting any money. So they need emotional support till the end, and we get the status report. The other group is those people who have lost a family member with guilt feelings, with depression, not able to sleep, the survivor guilt. These are the people who come in later. To them also we try to help. All they need is a consoling hand. When the patient comes to you, they want you to hold their hands. They want you to hug you. They want you to hug them. This happens not only with the female patients, but with the male patients too. They consider you like a father figure. But we can't do that now. So over the video or audio, we try to help them. This goes a long way to make them feel better. These people, they don't unnecessarily disturb you. They know that. Sometimes it's a WhatsApp message, sometimes for a few minutes, but whatever help we are doing goes a long way to help them. This psychosocial support, the role of it cannot be underestimated, and many people are doing it. Thank you.
Thank you, ma'am. And Dr. Kanagavel?
Good evening, madam. Thank you for asking.
Dr. Kanagavel, we can't hear you. You're not audible.
Am I audible now, madam? Madam?
Yeah, fine now. Yeah.
Madam.
Yes,
Thank you
Kanagavel,
for,
please go on.
I've been listening to both speakers and the thought sharing by the eminent faculty across the state and over the country. Madam, I have a question. In fact, we have been teaching the postgraduates as well as undergraduates online, especially with this era of many of the doctors being posted to take care of the corona patients. Many times we feel them to be quite distressed, and they come back to say, sir, I spent so many hours with the patient, but still we lost him. And many times it is unlike other medical ailments. This is one thing which definitely do not follow any book rules. So we instantly lose them until the last moment. The attachment to the doctor is the only lifeline or the connect with the patient. Madam, I'd like to ask you, what is your thought sharing about especially these doctors who handle the critical care illness of these patients? How do you think on a personal ground they should maintain their confidence levels considering the amount of deaths they handle in a very short interval of time? Thank you, madam.
Dr. Maitreyi, are you in to take that?
Yes, ma'am. But
please.
Yes, ma'am. But I would like to regret to say that we did not deal with doctors. We were talking to lay people, so I'm not qualified to answer this question. I'm sorry. There may be other esteemed members who can give answer to that.
That's appreciated, ma'am.
Dr. Madam, Sabita Madam, Dr. VC Madam, can I?
Yes, Dr. Sabita, I was just about to call you. Please go on.
Yes, ma'am. We have quite number of healthcare providers, doctors and nurses, and that too anesthetists, physicians, even the non-medical assistants who are not qualified for the MD internal medicine or MD medicine, who have been put in that ward when they are not able to tackle, or when in front of them when they die. I think it's really creating a panic in them. They come to us, they come to the department saying that they are not able to sleep. They are hearing their voices that asking them for help, and have some dreams. And when the last when they saw them, so we have quite number of them. So when they suffer like that and anxiety is prevailing, they feel even incompetent, whether we are not competent enough to treat patients, then we are not in that position. So that way we have seen so many persons. We have treated them, that is reassured them, gave them some emotional support, because it's not only one or two, it is in a day, like even more than that. Okay, 10 to 20 they see sometimes. So that has happened in the second wave. So they are a bit dejected. They are even questioning their competency that is coming up. So we reassured them. We told them that in this era we have tried our level best. So not to worry about that, giving some emotional support, and sometimes we have to give some anti-anxiety management also, madam. Antidepressants and anti-anxiety management when they are sleepless for a very long time, and they are a bit worried, and they are not returned sometimes to duty. They say that when they go back, they are reminded of those devastating events that are happening, that had happened, and they are quite in their dreams, and they are recalling that they are sometimes hearing voices also. One doctor told that I'm hearing voices of a young person, 20-year-old, calling me for help, which I couldn't help him, so I could hear his voices. Turning out to be a bit transient psychotic phase has gone in. So we could reassure, we could treat them, and they are all better now, madam. We are able to put them again back into duty. That's happening with them. Some are depressed also. So we have to give some mild antidepressants like that of escitalopram. We give them. So they are coming up very well. But it is sometimes very problematic. Okay, right? Even for the healthcare providers, when they are not in a position to handle the situation. So that's really happening nowadays, ma'am.
Dr. Niranjana Devi from Trichy. Dr. Niranjana Devi, psychiatrist from Trichy, from KAPV Trichy. Ma'am, are you inside? Dr. Niranjana Devi?
Ma'am, yes, ma'am.
Yeah, ma'am, your opinion and your experience in this
Yeah,
regard.
ma'am. I'll share you, ma'am. I'll share you.
Yes.
Ma'am, actually, as I do agree with Aditya sir. He told about, from the start, I'll share my experience, ma'am. First about Aditya sir. He told about the cases in series. He has brought about the delirium cases in this occasion. I want to share my experience in our Trichy Medical College. In the initial phase, that is in first wave. In first wave, we have seen less number of delirium cases. In this second wave, we have coming across so many number of delirium cases. Dr. Aditya was telling that we have to follow them for chronically to see the chronic changes. I do agree with Aditya sir for in that point. In second thing from Maitreya madam, we have also done telecounseling and we are doing telecounseling in our medical college. We have done more than 16,000 number of telecounseling till May end, ma'am. In the telecounseling, I do agree with the point she described in her version. But here, we have some difficulty in following up the patients. As a patient and attender are giving their phone numbers in hurry, we couldn't follow very properly. Apart from that, they are telling the same point. When getting their call, when getting our calls, they feel happy and they feel satisfied that we are here to care for them. That is the additional point from them. But in the first wave, they were telling that they didn't pick up the calls in the first attempts because there were so many calls from corporation side and so many aspects. But in second wave, they are picking up the calls and they are feeling stress free after our calls. And in addition to that, we have seen some amount of anxiety cases in our college. I sent my assistant in and I relieved the anxiety of few patients and we made them settle, ma'am. These are all our experiences and we are following up the patients very keen. And I have made our postgraduates to do studies in these aspects, ma'am. So we are following up the cases.
Thank you, ma'am. Dr. Raghotaman from PSG Coimbatore. Sir, would you want to specifically say anything about doctors getting anxious and, doctors evincing symptoms, psychological symptoms due to the workload and due to the circumstances into which they are thrust in?
Yeah, absolutely, ma'am. Good evening, ma'am.
Yes, sir.
I fully agree with the previous two speakers who say that these doctors, especially junior doctors who are at the front line, and also like another senior consultant talked about nurses who are the front line. They have been seeing deaths in front of the ear, in front of the eyes, and the workload they manage. Everything definitely causes lots of stress and lots of anxiety symptoms, which result in significant psychiatric symptoms. Actually, ma'am, if you permit me, I like to talk about try to shift the focus on patients having severe mental illness. This is a big vulnerable group, ma'am. In fact, there are reports published saying that these kind of patients having severe mental illness are more prone to contract COVID illness, and also the severity of the illness also seems to be much higher. I think the reasons are very obvious. These patients may not follow the public health advice, may not be able to keep the distance as told by others, may not be wearing masks, and also they may be discontinuing medications, they may be discontinuing blood monitoring, and all sorts of things. So this group of patients are more vulnerable compared to general people, general population to contract this illness. Also, when there are reports saying that these kind of patients are also having more risk and mortality is high in this group when they contract COVID-19 compared to general population. So all these things are matter to concern. And one more thing about the same severe mental illness patients. I had an experience in the last 2 weeks to know that same medication, same dose, when they contract COVID-19, the patients are not able to tolerate those medicines. Either they become too drowsy, either because of fever, dehydration, or some electrical imbalance, they become so drowsy. So our general advice to this group of patients is immediately if you get fever or any sign, reduce the dose. And I had just like to quote one more example. Recently, one of such patients was admitted in a private hospital, and that doctor stopped all our psychotherapy medications. I think wisely, because this patient was getting cocktail of medicines. But after discharge, 2-3 weeks later, she went into severe depression. That's the other extreme, where we stop medicines and they go into big relapse. So like we have psychosocial support for normal group, I think these kind of patients with severe mental illness need extra help and extra support from professionals like us. Thank you, ma'am.
Thank you, sir. I think it's now time to call Dr. Jagadisan to deliver his lecture. May I request Dr. Srividya? Srividya, you're in. Dr. Jagadisan, Dr. Srividya takes the liberty of introducing you to the audience today. Srividya, please.
Thank you, ma'am. Dr. Jagadisan is presently the professor and the head of the Department of Psychiatry in MMC and Rajiv Gandhi Government General Hospital. He is a graduate of Stanley Medical College and is one of the proud students of our esteemed Vice Chancellor, Madam. He did his master's from the Institute of Mental Health, Premier Institute, attached to Madras Medical College, and has served as a faculty member in all the city medical college institutions and also in Coimbatore. And now he is presently holding this position in RGTH. His special interests are in anxiety disorders, depression disorders, somatosensory disorders, and the current rage, the internet and gaming addiction among adults and children. He serves as a member of the Board of Studies of the Psychiatry in Tamil Nadu, Dr. M.G.R. Medical University. And when he held the post of Associate Professor in Institute of Child Health, he was the one who started the insurance scheme for autistic children. And he's also a member of many other associations and has published many papers and speaker in various programs. Over to you, Dr. Jagdishan.
Thank you, Srividya. That was kind of a very liberal introduction, kind of extensive. First and foremost, good afternoon all. And I would like to thank VC ma'am for giving me this opportunity to speak in this webinar. It is my pleasure. And let me share my screen first. I hope it's visible.
Yes, sir, it is.
Thank you, ma'am. When I was asked to talk today about some topic, I thought that psychological needs in children and adults, many of the previous speakers, they are focused on people who are suffering from COVID. I think we have to see apart from people who were suffering from COVID, as well as the people, general population and children who have been isolated and who are kind of struggling to cope up with the situation. So for the past more than a year, our lives have become changed, unique. I don't see any of us have experienced this kind of situation anytime in our lives. All our entire way we live, the domains it has impacted, like our occupation, education for the kids, the way we function in our home, as well as how we interact with our neighbors, because we have been so much restricted, it has changed. But I don't want to start with a lecture or a monologue stating that I want to talk about this and all. I want everyone to be actively involved. So I have compiled this module basically for not only psychiatrists, but also for non-psychiatrists. Like, since majority of the people in the crowd are non-psychiatrists, I'm presenting the case scenarios which I have seen in the past 1 year or 1.5 years after the start of the COVID. And I would like people to share in the chat box what they feel about these case scenarios, so that it will be kind of a polylogue rather than a monologue. So let me present this first case scenario. This is regarding a 40-year-old homemaker. She came to me with a complaint of sleep disturbance, worrying thoughts that if her husband would contract COVID whenever he returns home from work. She also complained of palpitations. She became dizzy hearing the news of COVID-related deaths in television. She was tearful. This was there for the past, for about 3 months. And in fact, during the kind of total lockdown, she wanted to consult. She took a e-pass for traveling between the districts. She was from Ranipet, and she consulted for this because she felt that she can even contract COVID and die from it rather than suffering from the fear. So I'd like to give few seconds, like maybe 10 seconds, for people to just put it in the chat box. What do you feel she could be having? Do I get some answers in the chat box? Yeah, I keep getting answers from lots of people. I would like to have more answers from almost all the participants. Yeah, Dr. Sabita has told it as anxiety. We have got an anxiety adjustment. Yeah, we get lots of answers. Yeah, okay, let me continue. I think most of you have given their answers.
Dr. Jagdishan, sorry for the intervention.
Yes, ma'am.
Describe it by whatever name, but I think universally everyone has been having this kind of symptoms and feelings and fears.
Yes,
everyone,
yes.
every one of us.
I'm getting into it, ma'am. I'm getting into it. Yeah, it is the anxiety disorder. Dr. Aditya rightly pointed out, this has become the commonest kind of psychiatric morbidity or psychological symptoms which people are having. But what the unique aspect of this is that the anxiety symptoms are revolving around the theme of COVID. And most of the anxiety symptoms, sleep disturbance, feeling anxious, fearful, apprehension, whatever it is, it has been highly disabling psychologically, and the disruption of routine has been significant. So even you can have a term called COVID anxiety to describe it. So this has been he has mentioned in his presentation that it has been the commonest, and what we see here also, it has been the most commonest disorder after the advent of COVID. And what are the things which precipitate? So like most of the things, people, they tend to watch television, they get lots of information from the media, and a constant kind of fear and harm which is being projected. So it tends to increase the anxiety among the people. So what kind of intervention we are thinking about for these people? Because it's not only we just talk about the symptoms and leave it at that, because there are many people who are psychiatrists as well as non-psychiatrists here in this forum. So evidence-based sharing of information on COVID. So psychoeducation in a calm and non-threatening atmosphere, giving insight and correct information regarding the patient's doubts, will be very, very helpful. See, addressing the cognitive errors. For example, lots of these patients, they have this absolutistic thinking, like if we get COVID, it's the end. So most of the people with COVID anxiety, that is people who have not got COVID but worried about getting feeling anxious, they feel that if you get COVID, it's the end. So we have to deal with these things, maximization and minimization regarding the events surrounding COVID. And overgeneralization. For example, they take a single event. For example, in a relative's family, there might have been few deaths of say 3 or 4 people. They feel that if it's coming to them, then it is the same thing. So kind of lots of cognitive errors will be in this patient, which needs to be addressed. So for these patients, what we do is that advocate sleep hygiene, healthy diet, physical activity, healthy interaction among the family members, and definitely, as many of the previous psychiatrists have told, we need not be hesitant or may not be relying only on the psychosocial aspect. We also have to treat them with pharmacotherapy if their symptoms are moderate or severe or highly disabling. A course of SSRIs with a low dose benzodiazepine for a short duration was found to be highly helpful. So, hitting the second case scenario, like this was a 65-year-old man who reports with gradual onset of sleep disturbance. See, before COVID, he was a retired bank manager. Before COVID, he used to sleep by 10 p.m. and wake up by 6 a.m. So he gradually started sleeping late by 11, 12, 1, 2 o'clock. And now he reports he sleeps by 4 a.m. and wakes by 10 a.m. And he feels dull and tired during daytime and worries a lot about his sleep. So this scenario again has been told by Dr. Aditya, like I would like people to just mention about various replies. What do you think this could be? I would like the participants, I'll give them 5 to 10 seconds. Can you just type in the chat box, what do you feel would be the possible reason? Okay, as he told, it is the circadian rhythm sleep disorder. So after the onset of COVID, most of the most common biological function that has been affected has been the sleep. So eating habits, others have changed, but the most common function which has been affected being sleep is sleep. 8 hours of average sleep is common in a healthy adult. Like spending time with family members at night, indulging in reading news due to COVID pandemic, watching movies, or discussing about routine. This has happened quite frequently and has gradually extended the time for most of the members in the family to sleep. So I'm not sure whether it is biological, but there is an aspect of sociological aspect is also there, which has produced this sleep disorder. So usually what we do is that if the duration of sleep is 8 hours and there is the regular routine of the individual is not affected, we leave it as such. It may not be of much concern if the patient does not have any other symptoms. But if the duration or quality of sleep is affected and functioning is definitely affected, then we need to intervene. So for these kind of people, we advocate sleep hygiene. Sleep hygiene refers to kind of getting a good sleep so that your physical as well as mental health and your overall quality of life is maintained. We educate to them about the steps of sleep hygiene, which all of the psychiatrists might be knowing, but non-psychiatrists, they might be kind of it will be good for them to know, like you have to maintain a regular sleep schedule. You have to have a physical activity, avoid substances which reduce your sleep, avoid daytime naps, and not to force sleep upon yourself. Have a good sleep environment and not to do any stimulating activities 1 to 2 hours before the sleep. So coming to case scenario 3, like this has been a very interesting case scenario which I encountered around 2 weeks back. See, there were 5 doctors, all of them were schoolmates from Chennai. They were aged 41 to 42 years, who used to have a get-together of social drinking, say every alternate week. And even during COVID times, they used to continue with this. And all of them contracted COVID about the same time. Among them, 2 died. The 41-year-old doctor who recovered from COVID reports with total lack of sleep for the past 6 days, even with 0.5 milligram of alprazolam. His blood pressure was 210 by 130, and he had a pulse rate of 100 plus. And he consulted a cardiologist who started him on antihypertensives and cardioselective beta blockers. And he expressed extreme fear of dying. So though the physician has done all the relevant investigations, including an angiogram to convince him, he was not very convinced. Like he has been taking a non-allopathic Ayurvedic cocktail for his anxiety, but with no much improvement. So with lots of reluctance, he consulted due to pressure from his physician as well as due to doctor's wife. Can anyone tell what this could be? Can you just type in the chat box? So I'm unfortunately not able to access the chat box. Dr. Sabita has told it as hypochondriasis, because I want people to kind of, it to be a kind of polyglot rather than me telling about things. Post-COVID anxiety. Someone has told it as panic attacks triggered by COVID. So we have got quite a few replies. So alcohol craving. So I think the doctor is a teetotaler, because twice a week alcohol is being calling it as craving. Since many of the answers have come, so post-COVID anxiety, like it is not only necessary that the anxiety is present in people who are not suffering from COVID. Even people, many of the people who have recovered from COVID, and when they see some of the colleagues or some of the people who are very known to them succumbing to the illness, they have this it's become very common, and it's seen widely. Like once they recover, they have lots of difficulty sleeping. Because since they hear the news that many people die even after a month or so due to sudden cardiac arrest, and there is a reason for them to have this fear. And in these group of people, there's a particularly extreme lack of sleep, and their autonomic symptoms are kind of, it's more, and they are highly sensitive to somatic variations and very much concerned about the diet and their physical activity. So it's not only COVID anxiety, but also the post-COVID anxiety, which has characteristics of illness anxiety disorder, is kind of very common. So what interventions? So ideally, these when the person, since they are suffering a lot, it's not like we leave them by start them with counseling, but SSRIs or whatever anxiety medications which suits them depending on their physical condition, we select. And we have to give a proper psychoeducation about the mind-body relationship, because since he, being a doctor, he was very reluctant to seek the treatment. We have to explain to him how the connection between your mind and the body works. So psychoeducation, cognitive behavior therapy, activity scheduling will be good for these kind of people. So this is the case scenario 4. All these things were related to each other. So I want to put this in this club, all the 3 cases together. So this is regarding a 40-year-old lady who lost her mother 6 months back and brother a week back. So after she lost her mother, she had sleep disturbance and was able to cope with that. But after her brother's death in spring, she sleeps only for 2 to 3 hours. And then she abruptly wakes up. Her mood becomes extremely gloomy. She has a feeling a small work is a major burden and she's not interested in activities. When I go to case B and C, you can start typing for the answers for case A. So regarding case B, so she is a 40-year-old lady with history of treatment for depression. She has totally recovered. She came 5 years back, but suddenly she contacts online for consultation without assigning any reasons. But from a tone of conversation, she appears very agitated and irritable to the point of getting under the skin of the doctor, because I don't want her to take up the way she communicated. But somehow the online consultation was initiated. She reveals that only after the consultation that her husband was 52 years, died of COVID on the day of discharge when he was said to have recovered from the hospital due to sudden cardiac arrest. And this happened just a week back. She says that she has become unduly irritable towards children and elders in the family, but was not also able to do her daily activities. But she was able to carry on with the activities, but the main complaint she had was irritability towards the people in the family. So you can just type in your chat boxes, what do you feel these cases are? And I would like to tell about the third case. Like, it's a 73-year-old lady. Again, she last consulted about 5 years back for a depressive episode, took treatment, improved well. Later, she stopped her medications and said she was maintaining with some low mood, but said it was manageable and she was kind of able to carry on with her routine. But now she reported, with the first sentence, what she told was, "Doctor, you won't believe what I'm saying, but 17 of my relatives and friends died from COVID." And she was very guilty that many of them were young with small children, and she does not have any commitments in life, but she's still alive. She reports extreme sadness regarding the events. She was totally disinterested in daily activities, and she was not wishing to live in the present scenario. So if people are having thoughts about these three cases, they are free to kind of just type in the chat box. Dr. Raghotaman sir has told it as complicated grief, feeling of guilt, definitely it's there. So we get kind of getting lots of replies from people. So depression, grief, double depression. So there's a kind of it's a kind of a cluster of all these things. What we have seen in these three people, like bereavement and grief has become much more common during the pandemic. And we have seen it in numerous families. And this has a kind of significant toll on the physical health. So whatever it is, people have to go through it, unfortunately. So we know the classical symptoms of depression, what these things are. But depressive symptoms seen in grief may not be as classical, like, because as we see in these three different cases, like it can be in the form of a sad mood or being dull and withdrawn, or it can also manifest in the form of anger and irritability, kind of an agitated depression, or it can be in the form of an atypical depression with the increased sleep and food intake. So all these kinds of various forms of grief with depressive symptoms are seen very commonly. An intervention, see, there are two schools of thought. Many people say to leave grief as such, not to meddle with that. There's another group which says that if the grief is kind of severe and they have the depressive symptoms, which starts to impact their activities of daily living, we need to kind of intervene. I take the second school of thought, because once a person is suffering because of grief with severe depressive symptoms, we can't leave them as such. And supportive psychotherapy in the form of grief counseling would be definitely helpful. The Kubler-Ross stage of grief, which we commonly see, or which is commonly being advocated, where the person initially denies the death, later shows anger, then starts bargaining with God or whatever the power to get the dead person back, and finally goes in for depression and acceptance, is what we generally tell. But what is seen since there has been a kind of mass death is that it has been less seen. Relatives easily go into the stage of depression and acceptance very soon, because they see things happening in their neighborhood and kind of in their with families and friends. And grief is not limited to feeling of sadness. It can also involve guilt, as we saw in the last case, yearning, anger, and regret. And emotions are often very surprising. It can be either very strong or mild, like we see in this scenario. So there were two types, like instrumental grieving, where when certain people in the Middle Ages died, the family was focused about problem solving, kind of, with the emotions might be less, but how to handle the situation or the children with the without the person. Or it can be an intuitive grieving, where there were heightened expressions and emotions involved in the with the dead person about the personal loss in the relationship. So many were calling upon psychiatrists, counselors, and all. And many times we see them telling these people to grieve or react in a particular way. I think we should not force the grievers to be on a particular way. See, some people might have comfort crying out or sharing their experiences with the company, while other people may prefer to be with their own feelings. For example, I knew one of my close relatives who told that her mother died only after a month of her death. So we have to respect each and every individual on how they grieve and not make them react in any particular manner. So coping with grief, what is our role? So if as a grief counselor, a psychiatrist, or any other mental health professional is being in the position, we have to help the individual accept the reality of the loss, to help them to work through the pain of grief, to guide them to adjust to the life without the disease, and we can help them to maintain a connection to the deceased while moving on with their life. So as some people have mentioned, in this COVID pandemic, we have seen two kind of unique features: complicated grief, which we also see the other times, where the symptoms are intense and prolonged, as well as disenfranchised grief. This type of grief has become very common. When we hear about death of a colleague, a doctor, or an IT professional regarding another IT professional. So in their office, suddenly you miss a person in the middle age, you do grieve, but maybe the emotions are not up to the grief when you lose a family member. So this has become more common in this pandemic. Okay, now coming to this case scenario 5, this is a kind of 35-year-old lady who was working in IT department. So she took care of her father during COVID. She was also positive and got admitted with him. Both survived. And she reports with waking up in the middle of the night with nightmares, ambulance sounds, as recurrent thoughts of a struggle to get him admitted. She was checking other members for oxygen saturation very frequently. And she used to avoid news about COVID, though highly worried. So as Dr. Aditya pointed, like I think this diagnosis will be obvious. Yeah, people are coming with right answers. Yeah. So we see all of them coming with the right answers. This is, I feel, was kind of not as common as anxiety or a depression, but definitely it was present. Acute stress disorder and post-traumatic stress disorder was definitely present, especially with lots of people kind of witnessing things in TV, social media. We see the classic triad of symptoms of re-experiencing, avoidance, and hypervigilance. So we have to keep in mind about the presence of these things. It is not only for us to be involved with the COVID, for the patient to have suffered COVID, but even witnessing the same in television can produce PTSD symptoms. So this is again why I'm emphasizing on PTSD is that it is present in almost lots of people, maybe in a very less intense form, not amounting to the diagnosis. Maybe the severity of the symptoms are less, but definitely when you start hearing things over a period of time, this has been kind of quite common. So how do you deal with this? Cognitive processing therapy. There are various things like cognitive processing therapy, where you let the patient kind of learn to challenge and modify their unhelpful beliefs relating to the trauma. In doing so, the patient creates a new understanding and conceptualization of the traumatic events. So it negates the negative effects on current life. The other thing is EMDR, where you don't talk about the events or thoughts, but you use a flashlight or a moving limb or a moving fingers or something, where you help the person to relax. Or the stress inoculation therapy is used, where relaxation exercise, cognitive restructuring, breathing exercise are used to allay the stress and anxiety related with these thoughts. And definitely SSRIs, they are used for this. So I was working in COVID for nearly a year before I joined Madras Medical College. Like I was taking care of some COVID care centers, and later we were in the Guindy COVID hospital, and I was there for nearly 7 to 8 months, and we started the mental health care center in the Guindy COVID hospital with the help of Director Narayanasamy sir. So he was very helpful in that. And we used to daily interview the patients. And in fact, we did a study on more than 500 individuals with the help of PHQ-9 and depression, anxiety, and stress scale. So among the COVID patients, what we saw, the admitted inpatients where there was high level of anxiety, stress, and depressive symptoms during the early periods of admission, which gradually reduced during mid-admission. And actually before discharge, they were kind of relatively comfortable, and very few had these symptoms. So since I wanted to talk about both adults as well as kids, I have just two case scenarios, like for children, that is being the main kind of distress during these times. 12-year-old boy is reported to be constantly engaged in playing computer games, watching YouTube videos till late at night, till 2 a.m., waking up by 11 a.m. There has been a change in his dietary schedule, physical activity, but whenever his parents confront him, he becomes irritable. Even he was assaultive towards the grandparents. That was when they actually brought him for consultation, and he was throwing tantrums when the gadgets were removed from him. So do we have any answers for this? Can anyone type in answers in the chat window? Yeah, Vimal has got it right. Again, this goes along with the another thing. Another parent consulted for a 16-year-old boy who, till before the onset of pandemic, was very bright and a very obedient student. and was now engaged totally in computers from morning to night. So with very short breaks in between, and when online classes were happening, this has been a very common complaint among the parents. The people, they shift their browser window, they do something else, and whenever the parents come, they again get back to the browser and start in the classes. And again, he started throwing tantrums, and when he was confronted, he started shouting, throwing articles, and even threatened suicide if the parents proceeded further. So any answers for this? I don't see any answers for this. For the first one, we got something. So anyway, let me go to the next slide. So gadget addiction has been the most significant change, the negative change COVID has produced. So gadget addiction, internet addiction, gaming addiction, and oppositional defiant disorder. So these tend to go hand in hand together. And this has been the most common sequelae in children following suspension or restriction of school activities after the start of COVID pandemic. This is very, very highly challenging to treat for the parents as well as doctor. And it is not only the children who are addicted, it is also the adults who are commonly addicted. And part of the behavior is modeled from the parents. Parents who work from home or parents who do not work, when they are totally into gadgets, children have no other avenue. If there is no play, they usually tend to get hooked into gadgets. So this has been psychologically crippling the social interaction, the normal physical and emotional development in a child. So we can divide gadget, maybe for non-psychiatrists, gadget use, abuse, and addiction. So use is when you use it for a purpose, maybe school, colleges, everything is being done by gadgets these days in a kind of restricted social interaction. Gadget abuse is that when you start using it excessively, when it starts affecting your interpersonal relationships, it starts affecting your scholastics, and when it starts avoiding your alternate source of recreation. And you call it as an addiction when it becomes totally the only source of pleasure, where you leave everything else and you live in the world of gadgets, and dopamine squirts from the games are more powerful to be overcome by anything else. So we have valid diagnostic criteria. So we have a valid diagnostic criteria for internet gaming disorder. I do not want to go through each and every thing. I think most of us will be knowing what they are, and also the criteria for oppositional defiant disorder. The two most common things which have started affecting children in this age. So children who have this constrained access to, because of the lockdown, socialization, play, and physical contacts. See, these are the three critical elements for a healthy psychological development. And because of COVID, all the three things are affected in the child. So it is quite natural for the child to have frustration, anxiety, and confusion with limited peer interaction. When you add these gadgets, it leads on to a very kind of dangerous thing for the child. And most of the parents, how they handle is that they end up by saying, stop doing that, stop doing this. But children do not listen to that, and there's kind of chaos in the family. In fact, one of the families, they call me stating that daily there is not only a verbal altercation but physical altercation between the mother and the two kids. And but children do listen when we give them positive instructions and lot of praise for what they do. And it is basically the way you handle them which is important. So it is natural for children to feel stress, anxiety, and grief. We have to come to an acceptance of the fact. Then the children, like adults, also fear the lives of the loved ones as well as their own lives. And many of the children daily have lots of facts from media which are factually untrue. Even my son comes daily with something from the internet or from the media and asks me whether it is true. And I have to tell him with some facts that it is not so. So when the parents do not know how to handle the children in this kind of a situation, and when they show their anger towards them, it might lead on to a violent situation. So what is our role? It is to promote an environment where children can grow up and develop to their full potential, having fun and being safe and healthy. And we should allow children to verbalize. You have to ask them, because since being at home, you cannot restrain or restrict them. You should allow them to ask freely and express, and we should answer the questions honestly. If we do not know the answer, we should be frank enough to admit the truth and say we do not know, and we can help the child search the answer. So how to achieve this? Understanding the emotional needs of child, helping the child deal with the stressful and painful events, recognizing the signs of psychological distress. Sometimes we may, as parents, we may not be able to deal with that. We have to go in for a child psychiatrist or a mental health professional who deals with children and take their help. So you have to talk with children about COVID. You also have to talk about the rumors about COVID. And in this situation, the children are prone for violence, abuse, and exploitation, because many times we see children, when parents get admitted or get separated from the child, they are in kind of different social situation. So you have to think about violence, abuse, and exploitation and keep that in mind while dealing with the child. So again, similar to adults' personality, each child behaves differently, and we have to appreciate that some child might be dull, withdrawn, some child might show anger and hyperactivity. So all emotions are valid, and consider and understand them with empathy. Do not force the child to be in a particular way in which you like, and engaging in a creative activity with the child will be very helpful. Like it changes with the years. For example, a 6 to 9-year-old or a 10 to 12-year-old or adolescent, all these age groups might be having different routines and schedules, and we can help them to kind of stay healthy during this time of pandemic. And also, children should be explained that nobody should be stigmatized. Your neighbors might be having COVID and all, and you should make the children have a proper approach towards the news topics related with COVID and about handling sickness, death. This will kind of reduce lots of anxiety in the children, and it will help them to cope up with the situation, because it's something which is going to stay in their memory for a long, long time. And if this turns out to be a very pleasant memory for them, I think it will be a kind of a movement for them to cherish, and they'll pass on to their children and grandchildren in a very healthy manner rather than in a very negative manner. So these are the three dictums: listen, comfort, and reassure. So these three things are needed to be conveyed to the children. You have to listen to them, encourage them to ask and share questions. You have to comfort them, play with them, spend time with them, and reassure them that this will be a passing phase and things will change. So to summarize, psychological well-being is kind of as important as physical well-being in these trying times. An early detection of emotional and behavioral problems in children and adults and seeking proper remedies is important. As medical professionals, we should be aware that these are the common psychological symptoms. It may not be only psychiatrists, psychologists, psychiatric social workers. All the doctors should be aware about the common psychological symptoms in people during pandemic. And we should be able to advise them on the healthy lifestyle and pass on scientific information, leaving our subjective bias. So we know that many of the doctors will be having individual bias towards various this illness, virus, and how to tackle, but we have to pass on the scientific information which we have at the current period of time. Do not ignore or ridicule a person expressing emotional symptoms. When a person is in the ward, say in the COVID ward, or a person coming to OP saying that he's sad or depressed about this, you should be able to take it with empathy. And also you should be able to explain about the mind-body relationship between these people. And he has rightly pointed out in the first slide, Mr. Aditya, so about the psychological, biological, and the sociological influences at this point of time. And as doctors, our basic duty is not only kind of saving a person from cardiac arrest. See, if you're going to save a person from suicide, it is the job well done, and its role remains the same. So we should learn the basic tenets of handling grief, bereavement, and counseling. So it's not only for professionals, even general doctors should be knowing these facts. And with this, I'd like to end my presentation. Thank you.
Thank you, Dr. Jagdishan. That was a very wonderful presentation. Can I request Dr. Therani Rajan for his remarks? Dr. Therani Rajan, please. Dean sir, MMC Dean sir, இருக்கீங்களா? Can Can someone call emergency? Meanwhile, may I request Dr. Jayantini, madam?
நாளைக்கே வந்துடுறேன்.
வாங்க madam.
The most important thing we have to see in children is the maladaptive behavior, which is on the rise. It's very easy to talk about it, very easy to discuss about it, very, very difficult to manage, especially for the parents in this pandemic times. On one side, he has discussed about the physical maladaptive behavior regarding sleep, food, snacking, frequent snacking, and finding fault with the mother for the kind of food being provided, and the screen-related activities continuous, and obesity. He has already mentioned about it. I am not going to talk about it. The next is the academic issue. The academic issues we know pretty well. Lack of attention, concentration, closing the browser and playing with the gadgets, cheating the parents, hence ending up in problems. The teachers complaining the academic performance is coming down. So that is another thing. The third thing is psychological. Psychological, he has talked about the oppositional defiant disorder. The one thing I would like to say here is the family factors. There is a separation, maybe a separation in the family. The father is unable to visit the family frequently. He might have been posted somewhere else. He may not be able to work from home. So separation. The mother also will be feeling because of it. She has to take the entire load. And the next thing is the ethanol use. The father being at home, he may be abusing alcohol continuously, resulting in marital problems. And then comes domestic violence, attempted suicide, mother talking or father talking about going away or committing suicide. All these things the children are watching, they becomes a toxic environment for the children. Next comes the financial issues. Today I had 2 children where the father is no more, and the children are studying in he died of COVID. The children are studying in a CBSE school. The mother has to shift the children to a government school now, and also to a smaller place. The children are going to face problems. So the problems may be environmental, from the family, or from themselves. So we have to be prepared to deal with it. Only when the pandemic is over, we are going to see how things are going to evolve. Probably to some extent, the academics will improve once the schools reopen and when the routine is started. But the other problems, what they have seen, what they have gone through, we should prepare them. I sincerely feel prevention is better than cure, and it's not an easy joke at all. Hello? 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 Are you listening to me?
Yes, ma'am, you're heard.
Okay. Thank you very much. I don't want to prolong my talk. Then it will become a long lecture. Thank you.
Thank you, ma'am. Thank you. Dr. Ramanathan from Coimbatore. Dr. Ramanathan, can you give your remarks? Anything that you want to say from your experience, what you've seen?
I'm audible, ma'am?
Yes, you are.
Ma'am, some of my close relatives and friends, when they are in the COVID ward, they felt more of depressed and they don't want to take any treatment. They said, I am okay, comfortable. Why you are putting me? Are you going to kill me or what? These are the conversations that happened, and they were telling me like this. And it took a lot of 2 to 3 days time for the doctors to convince and go for treatment, ma'am. So especially when they are in the, in the oxygen, they think that somebody is going to kill them and they are not secured and they want to go home and be with the family. So that is the mindset. Things it's a more within 3 to 5 days time. That is my observations, madam.
I think this was a universal phenomenon. Once again, it was seen by several of these people across several hospitals. Dr. Aditya. Dr. Aditya?
Madam.
Hi.
Hi.
So what is your take on all these matters which have been discussed across?
So I think the second bit about people becoming very paranoid, feeling that they're being persecuted, something terrible is happening, is very common. I think many of my ICU colleagues will call it ICU psychosis. And it is a form of delirium with psychotic features, where because there's no day-night separation, because it's a very disorienting experience, many patients become very paranoid and persecuted. There is, I think, a general sense, I think the general public's opinion and knowledge about COVID-19 is also important. Many of my patients and friends and family have reacted very unusually to COVID-19. I don't think in India we've had ever so many people in our memory who have been exposed to so severe a threat and a life-threatening illness. How each person behaves has become now, I think, is on public show. So some people behave as we expect in hospital, and some people behave unusually. And unusual people behave unusually. So when you have people with personality disorders, unusual personalities, some of them refuse treatments that you expect them to be welcoming. So it's quite unusual. And there is also a problem with ignorance where people think, okay, this treatment is going to help me, that won't help me. Then in India, there is also this issue of people believing that, you know, all sorts of alternative medicine will save us as opposed to modern medicine. There is that general concern about modern medicine being, I think, useless. And as we have recently seen in the newspapers, people saying that it actually harms a lot of people. I think that's a secondary issue. I think the points that I think Professor Jagdishan has raised is very important. Also, the one thing that I think others have raised, and I want to highlight the one last point, is that the threat to us all is not over. This is what is so special about COVID-19. None of us really knows how the rest of this is going to play out. We are not sure whether there are going to be many more waves. We are sure that our lives have changed for a long time to come. And you know, our economic, our social, psychological relationships, everything is changing. I think it's very rare for us to have so large, widespread an illness and so widespread as a fatal illness, a potentially fatal illness that has so little hope attached to it. So although many people are surviving, many people are getting better, no one, not the lower middle classes, not the middle classes, not the wealthy, no one has confidence that there is a way of beating this in a way that secures us for the future. So the threat for the future, I think, will change us all psychologically, not just those who have suffered, not just those who are afraid, but all of us. And I think, as some people memorably mentioned, including the doctors and the carers and the healthcare professionals. So I think that has been really brought out beautifully. Thank you.
Thank you. Your point is very well taken. The threat is still not over, and we're not even sure as to where we are. Which wave are we riding, and how many waves more are to come in? Nevertheless, I think the picture is almost the same in every pandemic, tracing back some of the pandemics which had happened earlier. I was impressed when I read about the yellow fever pandemic in Philadelphia, sometime when George Washington was shifting his capital from Philadelphia to Washington. You could imagine how early in history it was. At which point of time, almost a similar picture happened. The description about what happened is people walked around with vinegar tied around their necks, you know, small cups of vinegar around their necks. And then they did not want to see anyone on the road. If they happened to see someone on the road, they ran, they turned back and ran, and did not want to walk on the platform, primarily because they thought the disease could come to them from the houses on the sides of the roads. So they prefer to walk on the median area of the road and so on. I think psychologically it would have been the same situation at that point of time. People would not have thought if they could come out of a pandemic of that proportion. So probably that is what all of us are in. And I see Dr. Rajan back here. Thank you, sir. I heard you had the Honorable Minister's rounds or something of that kind in your institution. Thank you very much for being back with us. As a pediatrician, what would you want to say about what Dr. Jagdishan and Dr. Aditya have told? Like, what is the scenario across the children? Sir, you're not audible. You're not audible. Something wrong with your speaker, microphone, whatever. Bell is calling someone.
Madam, in between, can I have one point, ma'am?
Yes, sir, please. Dr.
So
Ramanathan.
one
Yes,
of the major challenge, what I feel is, in these psychiatric conditions, the drug usage, which might also depresses the respiratory center, so which will also aggravate the scenario they might need. That is one of the major challenges what many people have been stating, ma'am. Though we have less drugs which is not suppressing the respiratory center, but still that is one of the major worry which affects the COVID patient treatment also, ma'am. It's my point, ma'am. Yeah. Thank you.
Okay. A valid point, and I think people who are involved in treating patients may have to take a note of the fact and have more kind of coordination in this regard. Yes, sir, I think Dr. Terni Rajan is back. Sir? Sir, Kekala. Meanwhile, Dr. Venkatesh Madan Kumar, if you're in, konja ready irunga. We called you that time, we couldn't find you. Yes, Dr. Venkatesh Madan Kumar also.
Dr. Ramanathan sir's point is, but we have IMH, we have both even COVID-1 and COVID-2 phases. We have a lot of major psychiatric patient admitted in IMH, madam. But no drug is contraindicated in treating our patient, madam, and no respiratory depressions are more compared to general population. Even we have less respiratory depression and we have less use of oxygen in our patient, but most of the patient we don't even dyspneic or they don't complain of dyspneic because sometimes the ignorance of the patient or they don't understand the illness. So they have we have using less oxygens and we don't have so much hypoxic patients in our IMH patients, madam. In our experience, no patients have hypoxics like other compared to general populations, ma'am.
Okay. Dean, sir? Dean, sir? கையை கட்டுறப்பா வரமாட்டேங்குது வருது ஏதோ something wrong.
Madam, and one more point, madam. Most of the your patient, old age patient, not only fear of death.
Dr. Venkatesh Madan Kumar தான பேசுறீங்க?
Yes, ma'am. Yes, ma'am.
கொஞ்சம் slightly louder, like you know.
Yes, not only fear of death, madam. They can also worry about the post-death sequelae. About what, who is going to done the funeral? என் பையன் பண்ண முடியாது, corporation வந்து பண்ணிடும். அந்த மாதிரியான fears also we have experienced some of our patients, madam. Not only fear of death, death is immaterial. We know we going to die one day. But இந்த மாதிரி situationல யார் எங்களை பண்ணுவா காரியங்கள்? ஆஃப்டர் டெத் வந்து எங்களுக்கு யார் என் பையன் பண்ணுவானா இல்ல கார்பரேஷன் வந்து பண்ணிடுமா அனாதை பணமா போயிடும் அந்த மாதிரியான fears we have experienced certain people experience, madam. We experience certain people, they especially old age people, they told like this of complaints frequently.
Okay, that is again some issue that requires a kind of coordinated approach, not only the medical fraternity, but I think it's even the social factor. Everything needs to be put together.
Ma'am, excuse me, ma'am. I'm Dr. Narendra. I want to share one point regarding Dr. Ramanathan's query, ma'am.
Yes, ma'am.
Whenever known psychiatric patients are admitted in our medical college, Trichy Medical College, the physicians are giving call to psychiatrists, ma'am. So we go there and adjust their doses, ma'am.
Okay.
If any benzodiazepine need to be adjusted, we adjust the dose, ma'am.
Okay, ma'am.
So patients are getting correct dosages. And another point from us is some of the unit chiefs, they will call regarding their relatives or known patients, ma'am. Ma'am, patient is getting more anxiety, please contact them, like that they will ask us. Whenever we contact them, it comes to know they are having hypoxia, ma'am. When they are having hypoxia, they present with anxiety symptoms. Then we'll make the decision to know about this and will correct the hypoxia and will make give clearance to the anxiety symptoms. That is an additional point. Thank you.
Thank you.
Madam, good evening, madam.
Yes, sir. Yes, sir. We can hear you, sir. Please go ahead.
Madam, during this COVID pandemic too, children are affected with the MIS-C, madam, multi-system inflammatory disorder.
Yes.
Multi-system inflammatory disorder in children. And many of them presented with the atypical Kawasaki-like illness. In last month, May month alone, 40 children were affected. And during this lockdown and during this last 1 year, children are all actually attending only online classes. And many of them are complaining about headache, migraine, stress disorder, and many of them are showing anxiety, temper tantrums, like that, madam. This is the experience which you have seen in during this pandemic. And about the third pandemic, actually, we are not very sure how the children are going to be protected. Other issues are spending time in house alone is a big issue for the children, madam. I think Dr. Jagdishan has quoted some clinical scenario. Some of the scenarios are very commonly seen, madam.
True, sir. This spending time indoors, I think that is slowly kind of, I don't know many people here who might be in this hall. Many of us who belong to a particular generation, like, when we were children, we spent our childhood outdoors. We played outside. We went to the roads. We were playing there. And it was a very common scenario. School lerund vanda paiya தூக்கி விட்டு எறிஞ்சிட்டு உடனே வெளியில விளையாட போறதுங்கிறது was a very common thing. And you interacted with many people. You knew what was happening, who was living next door, everything. நம்ம வீட்டு விஷயம் தெரியுதோ தெரியலையோ பக்கத்து வீட்டு விஷயம் எல்லா பசங்களுக்கும் கண்டிப்பா தெரிஞ்சிருக்கும். But slowly things changed as technology developed. Their concentration was more indoors. Every mother wanted the son or the daughter to become a superman or a superwoman, learning everything across, learning everything under the sun. 64 ஆய கலைகள் இல்ல 640 6400 கலைகளை அவங்க கத்துக்கணும். So put them into every classroom, everything. And ultimately there was absolutely no outdoor contact even pre-COVID. So probably post-COVID or per COVID, it has worsened, and children remaining inside the house, caught inside the house, has become almost like, the dictum of the day. But then my question to all of you, Dr. Therunirajan, Dr. Aditya, and Dr. Jagdishan, the one thing that has affected everyone in this pandemic is the kind of infodemics that we have had in the social media. Epidemic, the kind of infodemics, all kinds of good things, bad things, all all things that need to go down the drain, everything has been there in the social media. Now, what do you think had been the impact of this kind of infodemics? Any one of you? Dr. Aditya, would you want to say something on that?
Ma'am, I just said 2 points. One is, I think you're absolutely right to call it an infodemic. I think we are all learning to see how we discriminate between different sources of information. The problem is, especially with WhatsApp, we are getting very dubious information from very trusted sources for the first time. So people that we know and love are sending us extremely problematic messages. And some of us are unable to discriminate between what is fact, what is fiction, and what is just fake news. The second point that you alluded to, I think, is very important, which is we are all experiencing what people in isolation experience, which is prisoners who are in isolated imprisonment experience a lot of mental health problems, and many of us are experiencing that. I wonder if you have that as a combination, which is both being isolated away from our usual social network, our usual normal life, and having information coming through what is now our most trusted information, which is our mobile phone. This has now become our friend and partner. And as Dr. Jagdishan says, most of us are somewhere between abuse and addiction in our relationship with our phones. And I think that is a problem. And I think this is going to be a problem for the future, because more and more people are aware of our vulnerability to this information and will exploit this for their own use.
Dean, sir?
Yes, madam. I don't
In the
have
social media issue, as an administrator, the social media issue எந்த அளவுக்கு பாதிச்சிருக்குன்னு நினைக்கிறீங்க சார்? As an administrator who's heading a major hospital.
Madam, that negative messages which is circulating in the media as well as in the WhatsApp, which is hindering the vaccination, madam. Mainly it affects the vaccination. That is why many were not willing to take up the vaccine in the first place itself. Even our healthcare workers were not willing to take up that vaccine. And then slowly it picked up to 90%, 85 to 90%. Now it is actually that I think that is very important thing, madam. That has to be taken into important count. And then government has to take a very serious note on it.
I think we are almost drawing to the close of today's webinar. Information, experience. If we don't have anyone else in particular, may I request Major Dr. Raja to give his remarks.
Thank you, madam. As usual, this program is very useful, informative, and educative. Regarding the media, you said the wrong messages are coming. There are three types of people in the world. One is who knows nothing. Another fellow who knows everything. The third fellow is a half-baked fellow who knows something. He does not know something. But we are always happy with a fellow who knows everything. It's a top-class fellow. The fellow who does not know anything also, we can tolerate them. Only the half-baked fellow who is getting the news from all the WhatsApp and other things is the most dangerous, and they become a doctor, advisor everywhere and spoils everything. That is my comment about that one. And second thing about the doctors are facing the death body and all these things. They're so scared and all these things. I always recollect during our student days, I joined medical college some 65 years ago. In those days and all these things, as you know very well as a professor of anatomy, first 1.5 years we have the anatomy, and the anatomy theater, we see more than 50 bodies, and every day 3.5 hours we see the bodies only. And with the result, I've been so tuned, there is a death is nothing for us. Nowadays, the medical students, medical colleges increase in number, and these people just now the enough bodies to the dead bodies and other. Sometimes they got the models also. With the result, they are not able to understand what is the real death and all these things. And second thing is, as I always tell the medical students in the student career, they should know how to face failures also in life. All the time you cannot get success in life. Sometimes you get the failures. In our days and all these things, suppose the 50% of the fellows pass an exam, there is a normal consequence. Nothing, nobody will blame for you. Nowadays, unless you get 99% result or 100% result, the teacher is feeling bad, the students feeling bad, the parents are feeling bad. With the result, they are not able to face the world. And when they face some disasters, they always feel very bad. This is my second comment. Third one, about the knowledge, they're training the people to counseling and all these things. Most of the people does not have the telephone, cell phones. Most of it does not have as far as the literacy state is concerned, they are not having so much of intelligence. And how these people can be approached and be guided by the health counselors. This is my thing. And as usual, madam, and the program is very nice. After it's almost now 2.5 hours, I think. And we, after seeing a good movie, we also, I feel very happy about it. And thank you so much. And I'm waiting for the third Friday of this month of June. Thank you, madam, for giving me an opportunity.
Thank you very much, sir. The point which our former Vice Chancellor made Sir, I think some shades I found a vice chancellor talks like that. Once you sit in that chair, there are certain specific issues that a vice chancellor faces, and that reflected in your comments. Thank you very much, sir, for being a support. One issue that Professor Raja raised is that the rural population, the kind of counseling that we can give to the rural population. And I think the same issue was well brought out by Dr. Maitreya also. Some of them don't have phones, they have no access to the internet. And how do we get across to them and talk in their language so that they get confidence in life? Not only confidence for the time being, but confidence in life itself. So that is one issue I think that all psychiatrists, psychologists, all those who are involved in counseling will have to think about, even the medical administrators. With that word, we conclude this day's webinar. And as rightly pointed out by our former Vice Chancellor, we await the next webinar, which will be on the 18th of June. 18th of June, Friday, once again, 2:30 Indian Standard Time. We would meet again for the next edition of the webinar. We have all your contact information. We shall keep you posted as to what the topic is and who the speaker would be. Meanwhile, if you would want any particular area to be covered in this series, my request to all participants, if you would want any particular area to be covered, any particular point to be addressed, I think most of you are part of the WhatsApp group. We do use WhatsApp for a good purpose too. And most of you are in the WhatsApp group. You can either put in your information or your request or your opinion in the group, or you can mail me, you can send me a WhatsApp message or an SMS or some way to contact. You can send us the information as to what topic you want. We would try and cover that topic. Thank you very much for being a very, very strong support. A special thanks to all the three speakers, Dr. Aditya, Dr. Maitreya, and Dr. Jagadisan, our own Dr. Jagadisan. Thank you very much. Thank you very much, Dean, MMC, VP, Chengalpet Medical College, Dr. Ramanathan, Dr. T.K. Ravi, Dr. Shanti, Dr. Jayantini Madam, Dr. Sabita, Dhanalakshmi Srinivasan Medical College, Vice Principal, Dr. Niranjana, and each one of you, my very, very sincere thanks. Thanks a lot, and we meet 15 days from now. Thank you.
Thank you, ma'am. Thank you.
Thank you, madam. Wonderful program.
Dr. Therni Rajan.
Thank you, ma'am, for ordering a wonderful event.
Thank you. Thank you.
Madam.
Sir, Dean, sir.
Thank you, madam.
Sir, Raja கூப்பிடுறாரு உங்களை.
Therni Rajan.
Sir, good evening, sir.
I am very happy to see your face, and I am very glad that you are doing a wonderful job in the General Hospital. And I am very.
Sir, I am not able to hear you, sir.
Teacher.